touched or have the potential to touch a billion lives or more. May I now invite our distinguished panelists and our session chair and moderator, Dr. Rajin Pratap Gupta, Chairman, Academy of Digital Health Sciences, and former advisor to Union Health Minister, a global thought leader shaping digital health ecosystem, and he is the chair of the Global Commission for 21st Century Healthcare, responsible for designing health system, which was launched on the sidelines of the UN High-Level General Assembly on 15 December. Mr. Anish Chopra, the first Chief Technology Officer of the United States, who demonstrated to the world how technology can be integrated into national healthcare systems. And I'm very lucky to host him for the second time after 15 years. Dr. Sunil Kumar Banwal, CEO, National Health Authority, leading one of the world's largest digital health public infrastructures in healthcare. Dr. Anand Iyer, Chief AI Officer at Welldoc, a pioneer in clinical AI and digital therapeutics, transforming chronic disease care. Mr. Manish Goyal, Chief Operating Officer of the Mayo Clinic platform, advancing data-driven, globally scalable medical innovation. Ladies and gentlemen, this is a rare convergence of policy, platform, clinical AI. I request Dr. Rajin to take it forward.
Okay, one more. Okay, one more. We'll start in a minute. Thank you.
Good afternoon. Good afternoon. Thank you. You know, when we say empowering billions and sitting amongst those people who have already touched between 1.4 to 6 billion lives, these are actual people who have already done. There is no theory talk here. There's actual implementation. And I thank the AI Summit organizers, especially Dr. Abhishek Singh, CEO of India AI, and the mighty team for organizing this wonderful conference. And we know that we are talking of a topic that is unprecedented. Unprecedented in scale, unprecedented in scope. I'm not going to take much time on putting the prelude to this talk, but we know for sure that as ABDM, we have put up the digital health system. Now we need to use that system to empower 1 billion plus people. That's a humongous task. But you know, when we have such a task with no precedent, there is no precedent to have implemented such a system at scale anywhere. And we also know that if we look at the world, America innovated first in the system, Europe regulated first, India reached scale first. So we have to see how the world has moved in terms of digital health. I'm very lucky to have with me a distinguished panel, someone whom I have respected a lot for what he has achieved, Mr. Anish Chopra. And we have seen him, what he has done to the world. He has taught the way you use technology for health. So Anish, given your global experience, given what you did for United States, what's your message to India, which is trying to reach 1.45 billion people with digital health?
Well, first of all, thank you so much for moderating, and it's an honor to join you on this panel with my wonderful colleagues. 15 years ago, President Obama visited India, and I had the pleasure of introducing him to Nandan and to Sam and all the legends of India. And after learning about Aadhaar and digital public infrastructure, he had one word in response: leapfrog. That in many ways, India was positioned to leapfrog what we had worked in the American governmental systems to think about what it would be like if we could actually build a sense of abundance and to give access to everybody to high quality information and service. And I think today the message is very much the same. The theme of AI Impact Summit is the right theme, which is to move towards democratizing access to high quality healthcare for everyone, empowering individuals with their information and the tools that can help them make sense of it at every step of their health journey. My message is one of open collaboration. As India looks to scale these technologies, my hope is that the underlying data standards and the information architecture can be exported not only in the global south but around the world so that they can empower everyone in a similar way. And throughout this discussion, I think we're going to get into the heart of that matter. But at the moment, those, as Mevish said at the beginning, the fragmented pieces of health information that need to be aggregated longitudinally in order to help understand what is the right next step in your health journey. Manish is going to share with us what he's done to make this available at a massive scale with the Mayo platform, as you'll hear as well from Anand on the tools to help people manage their diabetes. This is only going to get better, and I'm hopeful with your leadership we can do this together.
Thank you, Anish, for setting the context. Very well done. I think you should have been the chair. Nevertheless, moving to Dr. Sunil Barnwal. Dr. Barnwal, with 860 million ABHA IDs. Do we have a precedent? No. And we know that, this entire AI summit overly get focused on health. Every time you see, everyone is walking and talking the health session. I don't want to put you under pressure, but for sure, the expectation runs high. So how do you wish to boost the adoption of ABDM and its associated networks that you're building? What's the plan? How are you going to leverage AI? Yesterday we saw my former boss launching 2 big initiatives, Bodh and Sahi. What next?
So thank you. It's wonderful to be in the panel which is discussing billion health records, and it's indeed a privilege to be part of this journey where India is aspiring to actually leverage AI at population scale. What good thing has happened with India is creation of a digital public infrastructure in form of Ayushman Bharat Digital Mission. And you mentioned it correctly, the foundation has been created, architecture is in place. We have a system by which health systems can talk to each other. It can be interconnected. So there is a platform which is open, interoperable, and there is an architecture which is federated. With this in place, we see there is no challenge technologically to scale any AI solution to a large population like ours, 1.4 billion. Now where the challenge lies, and that is what Rajendra ji has just mentioned, how do we create awareness and enabling environment by which people just on board onto this system? They get, this ABDM gets adopted across the facilities, across the professionals, and people start demanding digital health records. Today we have 860 million ABHA IDs created for our citizens. But there are only 880 million health records linked to this ABHA ID. That clearly shows one person will have more than one health records. But the data shows on an average, one ABHA ID has 1 or 1.001 health records. That shows how much work we need to do more to link health records on this architecture. This is possible if we really make adoption very easy for the health facilities. And for that, there are methods by which we are enabling adoption of ABDM. One is, create a mechanism by which we actually incentivize the hospitals to come on the integrated system. Right now, as Anish also mentioned, we have a quite fragmented healthcare system. It's lying in one hospital, one facilities, episodic incidences, treatments. And here is the case where these all can be interconnected. They can talk to each other based on consent mechanism with a very secured system in place. And this we can we are doing some kind we are running a scheme which is for digital health incentives, where we incentivize per record creation, which many hospitals can take advantage of. Second, we also want to reduce the friction which a person has with the hospital. And that we are reducing through new applications like scan and shares, voice to text applications where the patient doctors interactions can be completely effortless, and this can directly create standard health records. So this is one, and then also making hospital facilities, professionals and the individual aware of the advantages in the future they will have. Patients can see the advantage because the whole system is centered, focused on patient. Every time they go to the hospital or any other facilities, they get their electronic health record linked to their Abha ID. Over a period of time, they can generate longitudinal health records, which will help them in many ways. It can actually alert them against disease. It can predict the future health of the person, and therefore he can be very cautious. It can also allow the doctors in the next visit to have a better diagnosis and therefore a better treatment. So this all are possible, and we are trying to make the whole system aware of the advantage. And it was rightly said, we have met the infrastructure, railroad is ready, the trains have to run. And we need to get more trains to run on that, so that the people who are making the journey, the citizens who are making the journey, have the seamless experience. So that is how we are trying to reach out to billion plus population.
And Dr. Sunil, under your leadership, I can tell you not just the train, but the first bullet train will be the digital bullet train. I'm sure about that. So Anand, coming to you, where most of the people think that AI analyzes your records. In your case, you lead to better outcomes. That's the wonderful thing you have done. You become father at a very young age, a father of digital technology, which people rever now. What's your message to India when it comes to adding value to ABDM, your experience of what you did at WellDoc, and what innovations you would prescribe?
Yeah, first of all, Rajan, thank you for your friendship and for your leadership on this panel, and it's such an honor to be with all of you guys. Really appreciate it. For those of you who may not know me, I serve as Chief AI Officer of WellDoc, but I'm a type 2 diabetes patient myself. And many, many years ago, I was inspired by my own condition to say there's got to be something we can do with digital health. When you think about the data continuum, while we talk about data fragmentation at the national and international level, and then we talk about data fragmentation within the health systems, I'm talking about data fragmentation at the N=1 person level. So think about it. There's data, information, knowledge, action, and outcomes. It's the data value chain, okay? The data is necessary. It's the first domino that needs to fall in order to extract value, okay? So as a patient, I use the acronym of MEDALS, okay? M is medications. I need to manage my medications throughout the day. And I may be on a cocktail of medications if I have diabetes and hypertension and something else, okay? E is education. There's educational content that I may want to consume. And it could be in the form of courses. It could be in the form of me reading, watching a video, understanding the effects of hypoglycemia, things like that. D is diet. D is diet. And my diet is very different than anybody else's diet because it's my diet, okay? So there's a level of personalization. A is activity, which is both sleep and exercise. L is labs, things I can measure, quantitative measures. Means my blood pressure, my blood glucose, my weight, my LDL cholesterol, things like that. And then lastly, S is surveys and symptoms. I'm feeling tired, I'm feeling shaky, I'm feeling sweaty, or I'm feeling shortness of breath if I have congestive heart failure. So I, as a patient, have to manage all of those vectors simultaneously throughout the day, throughout the week, throughout the year. And there's a small thing called life that gets in the way every now and then. So we ask a very simple question. Can we empower, through proper clinical guideline, evidence-based guideline guardrails, can we empower AI agents to help a patient manage these multiple things that they need to do? Okay, I'm sitting at a restaurant and my glucose is 228 mg per deciliter. What should I eat? How much insulin should I take? So now you have these agents that are working alongside that individual patient. And the instructions they're getting are literally, I call it Google Maps for a patient. Google Maps doesn't wait till you're 40 kilometers off track before it tells you to make a turn. As soon as you're off track, it says, hey, make a U-turn at the next place and come back, right? Why can't we do that for health? And so what we did at WellDoc was we said, let us build an AI-driven platform that gives the turn-by-turn instructions to a patient who may be hypertensive and diabetic, who may be heart failure and diabetic, whatever the combination is. But clinical guidelines are there to help train the models. And then we power those models with data, that person's data. Okay, for me to get an SMS saying, oh, you're diabetic, you better lose weight, I know that. I don't need an SMS to tell me that, right? But if I'm constantly suffering from hypoglycemia, maybe the thing to tell me is, hey, I noticed a trend. Well, these are the 3 things you may want to do to avoid it. So your notion, Doc, of doing prediction, we're very good at treating acute care. In the US, sadly, we'll pay you $100,000 to cut off your foot, but we won't pay you $10 a month to go get your foot examined for diabetic foot ulcers. We're very good at acute care. We have to use AI to shift that focus to prevention. And you use AI to then do prevention, prediction. And you know what, Rajan, the outcomes we're talking about? We're talking about a 2 to 3 point delta in hemoglobin A1C. You know that. That's a huge, 7 times what the FDA requires for a new drug, just by the patient doing the things that they should do. And the doctor is getting that. The doctor doesn't want to be bombarded with the data. Can you imagine that? Good God. That's the last thing that they want. The doctor is getting the information and knowledge to say, this is what's happening with that patient. Let's talk about this when we meet, either in a telemedicine consult or whatever. So you're bringing the doctor and the patient closer together. They're standing on technology's shoulders and they're reaching further. And that's the kind of outcomes, whether it's a 12 millimeter drop in systolic blood pressure or a 6 or 7 point shift in BMI. You're going to the root cause. I'll say this tongue in cheek, but I'm dead serious. The blockbuster drug of this century is the engaged patient. It's the engaged patient. If they do what their doctor has told them to do and they have the tools to empower them, that's how they get the outcomes.
Thank you, Anand. You know, if you heard the term software as a drug 15 years back, you'd be shocked, but this man did it. So this is Anand here. Now moving from this data to data platform, Manish Goyal is the Chief Operating Officer of Mayo Clinic platform. Mayo Clinic for 160 years has been the #1 hospital system. Manish, we are moving from hospital platform to data platforms. What's the relevance of what you do to India? And with regard to ABDM, we'll be very happy because our CEO is sitting here.
Data is always loud.
Yeah, there you go. So first of all, I want to echo what Anand said. Thanks for bringing us all together. I think this is a fun conversation, and I think as we get beyond the prepared comments, we're going to have a little bit of more fun because I don't think we always agree, and that's an important concept. I just want to define platform for everybody's sake. Oftentimes we use that term, but at Mayo Clinic we use it very specifically, which is it's not a piece of technology. It's a way of operating. It's a commitment that you're going to contribute something into a body and then take something out. So it's an implied contract that you're buying into, and it's an important concept around why we call it platform. So I just want to talk about 3 different things. One, historical Mayo Clinic, what we're doing with platform, and the last is why, because that why is the most important thing. So Mayo Clinic, as you just articulated, has been uniquely positioned as one of the leading hospital systems globally because we practice complex integrated medicine. When you come to Mayo Clinic, you get multiple specialties that evaluate your condition, that create a unique integrated diagnosis. That's why 32% of all cancer patients that come to Mayo Clinic, we change their diagnosis. That should give you pause because that's a really large number. We've been a 3-shield operation for 160 years. So that means we have a research institution. We do a lot of translational research. We have 2 medical schools, and then we have 3 sites in the U.S. where we see patients from 135 different countries in all 50 states. We're considered a tertiary quaternary center because we see a lot of complex patients. We're one of the largest whole organ transplant organizations in the world. Why do I share all that? That is the foundation of Mayo Clinic. The other things about the culture of this organization is that everybody at Mayo Clinic is salaried. We don't have physicians that come in as consultants. Everybody's salaried. Every single individual, from the cook in the kitchen to our CEO. Everybody gets the same salary bump every year. None of us have variable compensation. Those are important concepts because it sets the culture of the organization, and that is that the needs of the patient come first. If you pull somebody from the front line and poll them on what the core value of Mayo Clinic is, it will be that. If you poll a business person around how they make decisions around the needs of the patient. So I just want to set the foundation for who we are for a second, and then I'll definitely answer your question. The thing with the platform that we created 5 years ago was, how do we impact billions of lives? How do we enable sharing? How do we enable impact at a global scale? So Mayo Clinic's been on this journey for 6 years where we've digitized 100% of our data over the last 40 years. We haven't gone older than that, but we've gone 40 years of clinical history. Today, that's about 8 million patients and 30 petabytes of data. That's a massive amount of data that we have, a lot of it pre-diagnosis. And that becomes really important to Anand's point. If we can get ahead of any diagnosis in current form, which is you exhibiting a symptom, then we can actually get ahead of the problem. So at Mayo, we have over 300 algorithms that are actively running on patients walking in the door that do things like asymptomatic diagnosis for cardiovascular condition, or determining precision medicine, or determining the right therapeutic pathway. Those are important concepts as to the why. But digitizing the data wasn't enough. We said, how do we get to, in order to get to billions of patient impact, we needed to expand that scope. So we've gone around the planet and identified leading academic institutions to partner with us. So we today have 7 other institutions that have agreed to do that same thing, organize their data, but share it in a de-identified federated architecture. So we have about 55 million lives across the globe, representing 40% of the top 10 institutions, the number 1 systems in Canada, South America, Israel, Korea, Singapore, 3 countries in Africa, and later this quarter I hope to announce our partner in India. So now when you do an analysis, when you do training, when you do analytics, you're doing it on a global population. You're no longer doing it in a North American population, as has been the norm in healthcare, which is you test it on a North American or European population, and then you throw it out into the world, not worrying about the fact that it will likely not work in large percentage of the population. So we're getting ahead of the problem, and for the first time in our lives, we can do that. I just want to end with the why. So if you can diagnose a patient that would have otherwise had a fatal cardiovascular condition 10 years, 12 years, 15 years before they have any symptom, because we can do that now by looking at an ECG that a well-trained cardiologist cannot, but a machine can, that's impact. And if you can do that at Mayo Clinic, but then take that same algorithm and deploy it in a community site in rural Nigeria, that's global impact. Those are examples. Other examples are we're actually taking all this data and rethinking clinical trials. The entire idea of a placebo for diseases that are rapidly moving should make you feel really sad inside if you think about what we're doing. If we could do digital placebos, then people don't need to be on a placebo arm, and we can actually do that in a retrospective manner. So we're working with the FDA to make changes to this. It will take time, but if we can do digital placebos, then we can actually get to faster resolution of diseases or therapeutics. So those are examples of the why, but why is it relevant to India? I mean, you got a massive scale problem, and technology and digitization is the answer.
Thank you, Manish. We moved from AI to data. It's always the other way around. Coming now from culture to competence, capability, we can talk all these things. We will have a lot of technical maturity in the room in terms of tell me one problem, I can give you 100 technical solutions. But what is the organizational maturity? So it comes back to the capability we have in the room. Maybe you run the Academy of Digital Health Sciences. What is Academy doing to build the capability for digital health?
Thank you so much, sir. It's a privilege to be a part of this esteemed panel. At Academy of Digital Health Sciences, we believe AI and technology in healthcare, technology is not a problem. The problem is the workforce readiness. And that is where since our inception, we have believed that the main focus of digital health is the capacity building. And at Academy of Digital Health Sciences, we have trained more than 700 healthcare professionals, including the senior institutions presidents, the hospital founders and CEOs, the clinicians with more than 5 decades of experience, their medical practices, and we run courses which are dedicated to nurses, hospital owners, the founders of hospitals, doctors, and the paramedics, the pharmacists, because AI cannot be worked through one profession. We need to work in teams. A cumulative workforce is required. That is why we believe we all need to be trained in digital health. We are taking a next step and launching the Global AI Academy with global partnership between Academy of Digital Health Sciences and GenServe, where Dr. Rajin Pratap Gupta and the UC Davis CIO, Dr. Ashish Atreja, are the co-chairs of this academy, where we want the trainings to be taken globally for all the healthcare providers. And I look forward to taking this together so that the workforce is stronger enough so that we can deliver healthcare which is accountable and affordable to all. Thank you.
Thank you, Mavish. And with such a distinguished panel, we had reflections, we had positive disruptions, and we should have clarity of action. So I'm going to put 5 rapid fire questions to each one of them, and then go to your questions, because that is where we learn the most. First thing is I'm going to ask Anish, and then same in the order. One thing India must do in the next 12 months.
Well, I'm a guest in the home, so it's not for me to suggest what you do. But what I would ask is, as we think about the incentives to bring adoption, there may be an opportunity to bring the consumer voice first into that acceleration. And maybe there's a shared commitment to do this between 2 countries to learn. Just a reminder, the US has embarked on a healthcare empowerment journey to bring AI to the patient. In July of last year, the Trump administration announced basically an extension of what President Obama referred to as the Blue Button Initiative, that the consumer should be able to pull their health records and use them however they wish. We are now landing the plane. You saw the news that ChatGPT Health and Claude for Healthcare, the frontier AI models, have now built a secure AI service that can bring your medical records in a separate area and allow you to ask questions to make a difference. Those models will be applied in India under your leadership with different companies and in different approaches. But figuring out how that relates back to the doctors and hospitals as we onboard them in the system, that's going to require shared learning, incentives, and if we can do that together, I think we'll make a great deal of difference. So that's my, as a guest in the home, a request and an opportunity.
I think for next 12 months is going to be very challenging. The kind of questions which has come to NHA, and more so during this AI Impact Summit, I think the whole leveraging AI on the data which we have under the PMJ and the ecosystem which we are creating under ABDM is going to be the biggest challenge. And the immediate solution, and probably is the opportunity, is to actually take advantage of the technology which has already been tested in pilots to scale it to the population scale. And this is something which we have brought in form of a framework and a roadmap in the document which we have released yesterday, that the strategy for AI in healthcare for India. And this is where we will work for next 12 months to get it on the ground for large-scale deployment of the AI in healthcare. The aim is, as our Honorable Prime Minister says, AI in India means all-inclusive. So our target is to reach out to 1.4 billion citizens, make them part of this whole journey of AI. Thank you.
Thank you, Sunilji. Anand?
You know, I'll build off of what was said already. I think the spirit of collaboration that Anish said is really important. And I say that because we were one of the 60 companies who were actually invited to the White House to come and partake in this initiative where you're federating the data using proper authentication, secure authentication techniques. You're federating data that's already fragmented to bring that data into the palm of the patient, okay? That then those data points are used to guide the patient on their turn-by-turn instructions that our algorithms deliver. So it's the gasoline that fuels the Ferrari, so to speak. And you're bringing that high-octane gasoline to fuel the Ferrari, which is great. So collaboration is going to be important. But as Dr. Barnwell just said, I think we don't want to enter another phase of pilots. That would be really, really foolish because there's enough. Why is it that we send man to the moon once and everybody believes it, but for healthcare we have to do it 1 billion times to prove it? Come on. Let us move beyond this pilot phase and let's bring these things to scale. You know why? We will learn. We will learn from the first 30 days of engagement for a patient with a digital health tool. Their own data can then be used to predict, are they on a path for success? Are they on a path for failure? How should those data points alter the algorithms to then, push them back on a path of success? We have to do that at scale. When we do it at scale, the learning we get from these experiments skyrockets. Yeah, you can learn 1 or 2 things from a pilot, but you're not going to scale. You have to have large volumes. You have to have a base. And so I would encourage us to be bold. And you know what? What's the saying? I'm 100% sure that we'll get 80% right. But that's better than nothing. And we have to be bold in our strategy. And we have to be bold in our collaboration to harness this data and empower patients and empower physicians.
Thank you, Anand. Manish? Manish?
So I would just say, in many ways, India is already doing it. Just by hosting such a large-scale event, that's a necessary and first step. But I want to highlight 2 things that happened in the last 24 hours for us and for India that will be really important to do this much more scalably and to do it much more rapidly. So in the last 24 hours, Mayo Clinic platform and IIT, in this case IIT Roper, signed an agreement to allow IIT scientists access to this rich repository of Mayo Clinic's data to do development work, because the need to have clean, curated data is an important part of innovation. And then the second thing we did was to sign a partnership agreement with LOI with ICMR to start to create some validation programs for any results that come out of that. And if we can do that and do this 10 times over, 100 times over, 1,000 times over, that's how we actually move forward faster, because the concept of sovereign AI is important, but we all have to recognize that we still all live in the same ecosystem. And if we can collaborate, we can all get to the end goal faster, which is earlier intervention, better intervention, higher quality outcomes.
Thanks, Manish. Mavish?
I would say to increase the budget of NHA so that we don't go with pilots, but yes, to deliver the projects.
Thanks, Mavish. We saw a very interesting thing on the policy, on the standards, collaboration, being bold, and scale. Data is important. My next question is logical, given the fact that we are moving at very fast speed. What is a risk that we are underestimating? One risk that we are underestimating. Anish, you, then I'm going forward.
Well, this is a little bit of a challenge. Will AI be deflationary to healthcare costs, or will it be inflationary? And the biggest risk that I fear, if you look at the results in the US right now, the earliest implementation of AI is seen as inflationary. The health plans are complaining that the health systems are upcoding. And the health systems are complaining that the health plans are denying faster with AI. So we have a little bit of a back and forth that may not necessarily be in the best interests of the patient. So we need an economic model that ensures that the highest and best use of these capabilities and winning in the market is to help bring about an improvement in outcomes at lower cost. So that's my biggest risk, the risk of inflationary AI over deflationary.
Thank you. Would you also say that there will be a bigger divide with AI or lesser divide? That's another challenge.
That's another challenge.
Yeah, okay. Sunil?
I think there is a lot of risk which concerns a lot of people, more so when we talk of AI in healthcare. A lot of people are concerned about the privacy, a lot of people are concerned about the trust of the models which they use, and also there is a lot of challenge about disclosures, on which data is it trained, how relevant it is in the geographies where it is being applied. So these are several concerns, but still I'll say I think we must prioritize innovation over the restraint, and therefore whatever be the concern, the opportunity which AI brings can't be actually reduced or cannot be undermined with the concerns which we have. Of course, we have to guard against that, and that is why even the strategy document talks about it, and even the open benchmarking platform which we have launched today is also about testing the AI models against the Indian data sets, real Indian data sets, which makes it much more reliable. And that is why I think concerns are being addressed, but still the risks are there which need to be mitigated. The inequity or bias which is being also talked need to be mitigated, but we must harness the potential of AI to transform the healthcare delivery in India at a scale.
Very well said. Anand?
Yeah. I see two risks, Rajan. And one is a real risk and one is a perceived risk. The real risk is patient safety. And if we have algorithms that are rogue, we have algorithms that are not trained on the right demographic. I'll give you an example. We have an example where you can use a GPT-like algorithm. We call it a large sensor model, not a large language model. Because what it does is it takes a continuous glucose monitor sensor for people who knows CGM, you wear it on your arm or your belly, and it tells you glucose every 5 minutes. It'll tell you what the glucose is going to be 1 hour, 2 hour, 3 hours out every 5 minutes. That's pretty cool. And then you can tell the patient based on that, hey, do X, Y, Z so you avoid going low or avoid going high, etc. You can coach them, right? That model works in certain demographics if it's trained on certain demographics. If you apply that model in a flippant way to people that it doesn't apply for, then you're going to give them dangerous information that could harm the patient. So risk number one is patient safety. We have to do this with the guardrails of patient safety. The second risk is a perceived risk. We all hear about it all the time. It's prevalent throughout this whole conference. Is AI going to replace a doctor? Hell no. But I think a doctor who uses AI may very well replace a doctor who doesn't. So think about it. Just analogy. When you look up in the nighttime sky and you see a point of light, and you're like, oh, it's a star, or it's a planet for the more astute. But then you look in the Webb telescope, and it's 6 galaxies. Okay? AI is to the doctor and the patient what the Webb telescope is to the astronomer. It lets them see things that they can't see with the naked eye. It lets them see beyond. Oh, that's what the problem is? Well, let's fix that. Let's work on that. And so the second problem of perceived risk, I don't think it's there. I think we have to conquer that. Let's go and let's be bold again to my earlier point. I don't think there's any perceived risk. We need doctors, but we need AI to help them.
Thanks, Anand. Manish?
So I think the primary risk is failure of imagination. We're going to take this really powerful tool, and apply it to existing processes. So, to give you an example, research is a hypothesis-driven industry. Somebody really smart comes up with a hypothesis and then validates that through clinical trials or through validation studies. We're at a point where you could actually take large-scale data and have it itself, using AI, produce hypotheses that then humans validate. That could be threatening to the entire research establishment today. And if you give this tool to them, you could have them use it in a way that's somewhat pedantic. So we have to be bold and rethink how we do everything from administrative processes, clinical processes, research processes, in order to maximize it. Otherwise, we're going to add cost, to Anisha's point, against an overly burdened system already.
Navish?
I would say AI is not just one word, but a collaborative domain. So we should not look at AI single-handedly, but in the entire ecosystem of digital health.
Thank you. Now we're going to open the floor to questions. So please raise your hand, and I am sure there are mics that can be taken. Oh, wow, I see this. Okay, I saw the first hand out there to that lady on the left. So I hope that we can get you the mics across quickly. This one, Anshita. Be short, don't make comments, just ask questions, and tell whom you're addressing to.
My question to Sunil Kumar sir. Sir, how can traditional AI-driven predictive diagnostics be ethically and effectively integrated into healthcare data engineering systems to improve early detection of complex diseases such as cancer or any type of heart diseases?
Yeah, this is the beauty of it. This AI in our case has to be embedded into the healthcare delivery. And that is what the ABDM is enabling it. So we are not talking of any AI application as a standalone solution. So when we have created the data layer in form of ABDM, AI will be the additional layer. So any hospital, any professional wants to use it, actually it will be available. So the challenge is how to actually procure the AI solutions at the scale, but technologically it is not a challenge. Of course, training of the models on Indian data sets are the separate issues, but once we have a AI solution, its deployment is not the problem, and that is how it will work in the Indian context.
Kia ora, I'm Stuti Tiwari. I'm a medical student from Auckland, New Zealand. My question is, how do we prevent over-reliance on digital systems in clinical decision-making, and also how do we ensure that digitalization reduces hospital admissions, for example, rather than simply shifting care online? Thank you. Anyone on the panel? Thank you.
Maybe I'll just take a quick stab. We have a paper that just came out in the New England Journal of Medicine AI edition, looking at a way to create more transparency in model benchmarks to understand the underlying values that you see embedded in a training model. Back to your question, if you asked it, who should get the next kidney transplant? Certain models will answer one answer and others will answer another, and they have embedded in them biases as to where that allocation should be. So we need to have a little bit of vigilance. There's no one God model. There are going to be many models that are being trained, and there's no transparency in understanding what the current biases or values are that are embedded in that model. And so we're calling for more transparency on underlying models, and that could be the basis of discussion about procurement and otherwise. So we find those that are aligned to the values of our society.
Given this very interesting situation, though.
Let's speak.
Very interesting situation, though. Right now, we had second opinion and referrals from doctors. We will have AI second opinion referrals eventually.
Hello, sir. Hello, sir. I'm Dr. Ashish. I'm a faculty Department of Psychiatry, AIMS Bhopal. My question is to Dr. Sunil. Digitalization of health record is definitely required, but additional steps to ensure safety of mental health data. Is the government taking additional steps at a large scale? Second, whenever there is a collaboration between private sector as well as mental health professional, still I see lot of research on PubMed the ethical as well as legally safety guidelines are often overlooked. There are numerous papers. So is government taking or providing some checking or regulation body on those lines? Thank you.
As CEO NHA, I am not the expert on any particular disease or the health problems. But I can say that since you are in AIIMS Bhopal, and AIIMS Bhopal does use the AVDM system for electronic health generation, you will know that the patient record is still with the hospital and with the patient. It is nowhere else. In the system, it doesn't migrate anywhere from one hospital to another hospital or from anywhere to anywhere unless the patient has consented. So that way, the consent has been inbuilt by design itself. And the data which has was generated is at the hospital. So hospital anyway knows it, and basically is the issue of the medical profession. How do they keep that data with the doctors? So I believe the digital health system which is being put in place is nowhere conflicts with the privacy of that data. And regarding many other efforts of the government for promoting mental well-being or reducing mental health issue, I think there is huge deliberation, and you must have seen that there is a separate allocation in the budget for the mental health issues and challenges which the society and the country is going to face, and therefore there are much more focused effort to address these challenges. The details, of course, you'll get to know with the experts who are working in this field. You yourself in a medical institution will get to know if there is any scheme which is actually promoting mental well-being. So that is how, as of now, NHA is concerned.
We have to stop questions. Very well put by Sunil is, that this is the first case. I've always seen technology moves faster than policy. At least one thing I can say under the current leadership, our policies move faster than technology. That's for sure. And I'm sure that we will set a template for the world. I can't let this panel go without putting their last message, 30-second message. Anish.
Well, I mean, I think you just we want to jump on the bandwagon of what you want to see scale up in the next 12 months. That's an inspiring message, and I think we would like to see as much of that traverse globally, so there can be a shared learning and feedback loop as we collectively scale.
My message is let every citizen be on the Abha ID first. Let everyone get the Abha ID. Those who are in the hall, how many of you have Abha ID? I think many of you don't have the Abha ID. Please get it immediately. This is the ID for your health throughout your health journey.
The divine bell has rung.
No, I would just say we would love to collaborate with you, sir. I'll say it for Anish too. Both of us would love to collaborate with you, and we can figure this thing out together and be bold, and we can change the way we manage health for chronic conditions going forward.
If you have been in healthcare for more than a decade, this is the perfect time to be alive. You will leave a legacy on this planet that is much, that will have improved healthcare outcomes for generations to come through all the work that we're going to accomplish together. So I hope you're energized and exercised about this, as I am.
Maybe share the last word.
I would say healthcare will not become AI driven because only technology is there. It is because people need to be trained in it.
Thank you, Mavish. A big round of applause for the esteemed panel. Thank you so much.